is that before this wave of newly covered people arrives in 2014, before the Medicare population really begins to increase starting next year, we have the opportunity to develop some big state and regional demonstration projects in delivery system reform to demonstrate what a new delivery model should look like. Now, those of you who, and I think in that environment, the Congress is going to be desperate for big models in delivery system reform that they can point to when they take this issue up again, which surely they must. And I think there's an environment when we can get broad federal flexibility to experiment, to set up these demonstration projects. In the federal legislation, Senator Wyden got language in and kept it in that encourages states to seek innovation in the use of these new federal dollars for coverage. And the gentleman who's been nominated by the president to serve as the head of CMS, which is the agency that oversees Medicare and Medicaid and grants the waivers, is none other than Don Berwick from the Institute of Healthcare Improvement, the author of the Triple Aim, who really understands population health and what the delivery system has to do. So our opportunity is to try to set up those kinds of regional demonstration projects right out here in the Northwest. So let me take just a couple minutes and talk to you about the key elements that I think a system has to embrace if it's going to achieve the Triple Aim. Now, you could develop a number of different systems, but these are the elements that I think are going to absolutely be essential. First of all, revenue has got to flow to regionally organized or locally organized entities that assume responsibility for the health of a defined population, okay? In other words, you have to organize the delivery around defined populations, and the caregiving organization has to be responsible for the health of that population, not just of individuals within it. Now, that entity could be a hospital, like Kadlec Hospital, with an affiliated physician group. It could be a large primary care group practice. It could be an entirely new entity. Now, the reason you need to organize the delivery of care around a defined population is, first, it gives every individual in that population a direct point of contact, a medical home, if you will, an advocate or case manager to help them navigate that system when they need it and to develop the long-term relationships that are necessary for managing care, particularly acute care and end-of-life issues. Secondly, it allows you to provide a population-wide health education and wellness program and to identify individuals within that population who are struggling with the challenge of taking responsibility for their own health, whether that's smoking, whether that's weight control or diet. Third, it allows you to identify the at-risk children and families who are going to end up in the acute care system if you aren't on top of it. The kids who are now developing childhood obesity, who we know are going to develop type 2 diabetes, and we're going to see those kids in their 20s and 30s rather than in their 40s and 50s. Fourth, it allows you to identify people who need screening services, to do a thoughtful population-wide screening program to pick up the early signs of chronic illness and make sure you get on those early on rather than on the back end. So in other words, it gives you the capacity to identify and appropriately manage the 10% of the population that's driving 70% of the healthcare costs. The second element is we're going to be dealing with some kind of capped payment. Fee-for-service, as we know it today, is not going to survive into the future. We're going to have to manage to a fixed budget and manage utilization and cost to some kind of fixed budget. And I expect we're going to see the bundling of episodes of care, including post-acute care, to create the incentives to manage those episodes rather than simply the old fee-for-service system. Third, the new system is going to have to include what I would call value-based cost sharing, where co-payments and deductibles are used not just to shift cost to individuals, but rather to create incentives to purchase high-value care. So you may have no co-payments and deductibles for things that are extraordinarily effective in producing population health, and higher co-payments and deductibles to things that are less effective or more discretionary. So for example, you might have no cost sharing for screening for diabetes, hypertension, breast cancer, prostate cancer, things of that nature, and the medications you need to manage your chronic condition. Because creating any barriers to access to those kinds of things create huge human and fiscal costs downstream. But if you want to have your surgery for your low back pain, when there may not be evidence to suggest that it's any more effective than physical therapy, there may be a 50% copay. Or at the other end of the spectrum, if you and your spouse want to determine the sex of your unborn child through an ultrasound, when the ultrasound isn't needed for a normal term pregnancy and you're really just paying for curiosity, you can get that too, but you have to pay for the whole thing out of your own pocket. Now, value-based cost sharing recognizes two important things that we like to ignore in the United States. The first one is that people with more disposable income can always buy more stuff, including more health care. And secondly, we are always going to have at least a two-tiered system based on income, as they do everywhere else in the world. But, and this is very important, there should not be a qualitative difference between those tiers in terms of health outcomes. Okay? Now, find my clicker here. Now, even if we get our physicians organized in integrated delivery systems, working together as part of a team, and even if we can get our primary care physicians to practice to the top of their licenses, doing only those things that nobody else can do, dealing with areas of high ambiguity and allowing greater use of physician assistants and nurse practitioners, even if you create that kind of a system, while it will improve the health of the people who actually come to see you, it will only have a marginal impact on the health of the overall population. And that's because the real drivers of health are outside the formal medical system. There are these lifestyle and behavioral issues. There are cultural issues. They have to do with whether you have a job or not. There's ethnic issues, language issues, a whole host of issues that are not affected by just reorganizing the medical delivery system. And that means that the clinical system has got to work in partnership with other community organizations and entities that are focused on trying to mitigate the drivers of health, the determinants of health, to create a system that blends prevention and wellness with medical care to create what I call a true health system or health community. Now, in order to create that kind of system, and you probably notice it doesn't look anything like the system that we have today on planet Earth, at least in the United States part of it. In order to do that, if you're going to create a regional demonstration project, you're going to have broad flexibility in how federal dollars are currently being spent. And let me give you an example. Supposing somewhere in the Tri-County, Tri-City area, you have a 92-year-old woman with well-managed, stable, congestive heart failure, living by herself in a little un-air-conditioned apartment, okay? And you have a heat wave, which I understand you do from time to time up here, and let's say the temperature in her apartment goes up to 105 degrees for a couple of days. That increased temperature can put enough strain on her cardiovascular system to push her into full-blown congestive heart failure. Under the current system, you probably won't know about her until she shows up at the emergency room. Under the kind of health community that I'm talking about, somebody would be checking on her on a daily basis. Not a doctor, not a nurse, but probably a new community health professional whose job it is to check on all the non-medical aspects that impact somebody with chronic illness to make sure they're being taken care of. Under the current system, Medicare will pay for the ambulance ride and the $50,000 to stabilize her in the hospital. It won't pay $200 to buy her a window air conditioner, which is all she needs to stay in her house and out of the acute medical system. The difference is substantial. So part of this is asking for the flexibility necessary to use those new federal dollars to manage health rather than healthcare needs on the back end, which is a significant change. Now, I'm convinced that unless states and regions are able to step up, unless we're able to provide the leadership to say, if anything were possible, what would a system look like that could achieve the triple aim? It's not going to happen at the federal level. And both Oregon and Washington have a history of healthcare innovation. They're states that are manageable in size. We are certainly on the short end of Medicare reimbursement rates. We've got every reason in the world to step up to the plate. And it's very, very important, I think, that we do so. Let me close with just a little story to illustrate at least my view of how extraordinarily important it is for us to take this issue on and not simply wait out here in the last best part of the United States for the federal government to do something for us. My father was a member of what Tom Brokaw called the greatest generation. These are the people that weathered the Great Depression and fought in the Second World War. My dad served in Patton's army. He entered France through Normandy and marched all the way across Europe through the Battle of the Bulge to Berlin. And before he died, 5 years ago, I used to call him up every year on June 6th, which is the anniversary of D-Day, and I would thank him for saving the world.